Hi, everyone. Welcome to today's seminar. I am Rachel Warner, the Executive Director of the Letter Davis Institute at the University of Pennsylvania. Today's seminar is Has the U.S. Cured Healthcare Cost Growth? And thank you for joining us today for it. For decades, U.S. spending on healthcare has grown at rates that exceeded overall inflation. In 1970, healthcare spending, measured as a percentage of the gross domestic product, was 7%. That spending grew over the subsequent decades through 2009, when it hit 17%. And yet, since then, healthcare spending has been relatively stable, with the exception of the years during the COVID pandemic. The latest data from 2023 was released last month and showed that the healthcare sector's share of the economy was 17.6%, making growth essentially flat for over a decade. This is the longest stretch of no-cost growth relative to GDP since at least 1965, when Medicare and Medicaid was created. Stable growth of healthcare runs counter to historical projections. It also contradicts what many Americans experience with their own healthcare costs. And while spending is flat when measured as a percentage of the GDP, healthcare spending increased by 7.5% in 2023. And about half of US adults, even among those with healthcare insurance, say it is difficult to afford healthcare costs, and many Americans engage in cost-saving measures like putting off needed care and refraining from filling prescriptions. So we're here today to talk about the flattening of healthcare spending growth relative to the economy, why that might be happening and what might we expect in coming years, and also whether it's even measuring the right aspects of healthcare spending. Today, we are joined by two panelists. Unfortunately, our third panelist, Melinda Bunton, couldn't join us today because she got a bad case of the flu. But we are joined by Amitabh Chandra, who is the Malcolm Weiner Professor of Public Policy at the Harvard Kennedy School of Government. Amitabh serves on the Congressional Budget Office's panel of health advisors and has served on Massachusetts Special Commissioner on Provider Price Reform. Zeke Emanuel is a vice provost for global initiatives and the Diane V.S. Levy and Robert M. Levy University Professor here at the University of Pennsylvania. From 2009 to 2011, he served as a special advisor on health policy at the Office of Management and Budget and the National Economic Council, where he was instrumental in drafting the Affordable Care Act. So to start off, thank you both for joining us today. To start off, we had asked Melinda to give us a little bit of a background information, and since she couldn't be here, she sent me a few points from her notes to help us level set and understand how healthcare cost growth can be low, yet spending can continue to rise. So I will put on my Melinda hat for a minute and give you a little bit more background information. As I mentioned in my introduction, healthcare spending as a proportion of the total national spending has been flat since the late 2000s. Meaning that healthcare cost growth hasn't exceeded growth in the gross domestic product on average over that entire period. That does not mean it hasn't grown, though. The GDP has risen, inflation has pushed up prices for healthcare and for other goods, and our level of spending on healthcare has grown. It just hasn't outpaced economic growth. Also notable during this period, we've seen growth in the number of people with health insurance and growth in the number of older people who have Medicare benefits, making the lower rates of spending growth even more impressive. It's important to understand healthcare cost growth in historical perspective. For example, per beneficiary, Medicare spending grew at an average rate of 6.6% per year between 1987 and 2005, but by only 2.2% per year between 2013 and 2019. For this reason, the projected date of that the Medicare Trust Fund will be exhausted has been pushed out a number of times. Back in 2012, the trustees estimated that the trust fund would be completely exhausted by now, but their latest estimate has pushed that depletion date back to 2036. We'll talk more about this topic in a minute, but Melinda also wanted to note that research that she's conducted has demonstrated that the slowdown in spending growth is pervasive across payers, across types of services and types of patients. All that said, lower rates of growth doesn't mean that there's not wasteful spending going on and that healthcare is affordable. Those issues do remain. Melinda, I know, has a lot more to say on this topic, so it's too bad she couldn't be here with us today. She does have a piece that will be published soon on the role of what she's been calling the value zeitgeist in slowing spending down, so you can keep an eye out for that to learn more about her position on that. With that, Amitabh, I do want to move on to you and get the conversation started. Now that we've had that broad overview from Melinda, can you break down the trends by type of payer, which Melinda referred to? Are we seeing different trends by spending by payer, and if so, why? What are the different drivers of those trends across payers?
Thank you. That was an excellent impersonation of Melinda, and thank you for inviting me, Rachel. And it's great to see you, Zeke, on this panel. Um, so let me just answer your last question directly. In the data that I've seen, since the passage of the ACA, so let's just anchor that around 2010, growth in private health insurance has been much greater than growth in Medicare and in Medicaid. So when I say private health insurance, I'm talking about the sort of health insurance that someone like I would receive as an employee of Harvard University, or someone might receive as an employee of NVIDIA. Um, that those premiums, I'm not talking about the out of pocket, have risen much faster. So just since 2020, so sort of since the pandemic, it looks like that spending has increased about, 7% per year on average. And just in contrast, Medicaid spending per beneficiary looks like Medicaid at about 2.5% per beneficiary. So there's something that's going on in the public plans that the private plans are not able to do. Now there's a question of like who's getting it right? Is Medicaid getting it right, or are the private plans getting it right? And then just to put this into historical context, back in the 1990s, these three programs were basically growing at the same rate every year. So they were growing at about 6% a year. Whether you look at private health insurance, you look at Medicare or Medicaid, they're all growing about 6% a year. Then in the 2000s, when I became a health economist, right, Medicare and the private health insurance plans were growing at about 7% a year each, and Medicaid was at 2.5%. And now what's happened is Medicaid still stays growing at 2.5% a year, and it's really the private plans that where healthcare spending has continued to grow at about 7%. So I think the question for us, all of us, as physicians, as researchers, as economists, is like who's really getting it right? One way to think about it is, well, Medicaid's getting it right because they're spending less, the growth is a lot lower. The other is, well, maybe Medicaid is getting it wrong, and the private payers are somehow getting it right. They're probably both getting it right, but who's getting it, or they're both getting parts of it right and wrong, but who's getting it more right? So I'm going to stop over there.
Can I just ask a follow-up question? Do you have thoughts on why those rates are different from each other between, for example, commercial and Medicaid?
So my sense is that government payers have much more purchasing power than private payers, just simply because not because they can kick certain hospitals out of network as much as they can rely on regulated prices, right? And so you might be United Healthcare, you might be the single largest payer in the United States, but I'm not sure that United Healthcare is actually able to turn down how much it pays the Boston hospitals. You can't run a health plan in Massachusetts and not cover the Boston hospitals. If you're Medicare, what you can do is you can dial down the rates through regulated prices, through administered prices. And that's, I think, something that the private plans are really, really struggling with.
Zeke, you look like you want to jump in.
Well, first of all, I don't think it's, and Amitabh, you'd be able to, you know better than I, but I do think it's the case that some of the exchange plans in Massachusetts do not have MGH and Brigham, and they have lower premiums, as you might expect. I could be wrong on that, and maybe it's, gone out of fashion. But look, the fact is, and I think Amitabh implied this, and I want to make it very, very explicit, is that for the last 15 plus years, depending on when you want to draw the line, we've had flat growth as a percent of GDP. That doesn't mean that all sectors that are paying, whether government, private insurance, employers, and the people who actually get the insurance, those of us who are beneficiaries, are seeing the same burden, as it were. So one of the things we know that's happened over this time period is that high deductible plans have gone up, and therefore, people will be paying a lot of money to get past the deductible, that they might not have been paying in previous years where they didn't have a high deductible plan. I would point out, and I have said this, I do think one of the major effects that goes along and I think supports Amitabh's point has been the rollout and emphasis on value-based payment. It's way imperfect. Don't get me wrong. I'm having helped design a lot of those programs in ACA and pushed for Medicare to be more, CMS to be more active in rolling them out. It's taken way too long. I think that's mostly because we've had voluntary programs out of CMS rather than mandatory programs. But those programs have had, I would argue, a big effect, combined with the shift to Medicare Advantage and more capitation in that context, on practice. They've certainly, over time, we've seen less of an increase in the emergency room utilization. We've seen actual drop in hospital utilization and admissions. We're down below 100 hospital admissions per 1,000 Americans, which is historic lows. And that's exactly what you would expect with value-based payment changing physician behavior. They would decrease the utilization of the highest cost parts of the system, which are the emergency room and hospital care. The other thing we should note is that payments for drugs has come down a little bit, and that's mostly towards the end of the last 15 years, from 2017, 18 to today. They were going up higher before. And I think those two things are inevitably, they're big parts of the system. The last point I would make is to re-emphasize something, maybe to give a different accent to something that Amitabh said, which is the commercial plans and therefore employers have largely been AWOL on the issue. They bitch and moan about high prices and healthcare is out of control and but they have not really done very much in terms of really adding their weight to cost control. And they have all the margin for the various providers in the system. And I think that silence has meant that commercial plans have gone, commercial costs have gone up higher than Medicare and Medicaid. There are other factors, but I think that is a very important factor that can't be overlooked. They've basically done nothing except introduce high deductible plans, which now appear to have run their course for the last few years. Enrollment in them is flat at just under 33%.
So let me ask a follow-up question about alternative payment models. So you have suggested or argued that alternative payment models are in part responsible for flattening of the cost curve. Often when people look at the success of alternative payment models and look at like the portfolio of models that CMMI and others have implemented, they walk away with the impression that they haven't worked as well as we might have expected them to. And so how do you reconcile the power of alternative payment models to flatten the cost curve, but also their lack of success in really the goals that they set out for themselves?
Well, I'm not sure the goals they set out for themselves. I think the goals that are being used to evaluate them by the actuary, it's HHS. The fact is that, bundled payment for lower extremity surgeries, about 3% savings over time. MSSP, about 3% savings over time. And that I think is basically right. What that leaves out is a lot of spillover. And I think they don't monitor, the evaluation the actuary at HHS uses is very strictly on the program and the beneficiaries enrolled in the program, and not on the overall impact on the healthcare spend. And I think we have well-documented cases of spillover, and that's in large measure what we should expect. It is the case that doctors sometimes treat different segments of their patient population differently, but I think in general, that isn't the way it goes. They have a sort of standard operating procedure. That standard operating procedure occurs. I've written about cases at Penn where our orthopedics are looking, oh, we've got to save money. They weren't looking, we've got to save money only for our particular patients enrolled in with bundles. They were looking generally. I would say I've intersected with other plans where, because of in MA, they screened all their patients over 60. They screened their MA patients initially over 65 for mental health issues, depression, anxiety, and had a rapid intervention. But that, became successful, and they generalized it to all their patients. And so I think this spillover effect is much more important. It's really a mental change on the provider side, and you're not going to pick it up by the evaluations and only looking at the beneficiaries within a program for the full impact on healthcare spending.
Okay, thanks. So if Melinda were here, she would want me to ask you a follow-up question. I'm going to be Melinda again for a second, and say that she has noted that the spending slowdown started well before the ACA was passed, and although the ACA and value-based payment deserve some of the credit for slowing down spending, I want to talk a little bit more about what else is causing the slowdown in spending. So maybe I'll talk, Zeke, you can start, but I want to bring you back into, like, there's probably a lot of other things that we could talk about that are related to the spending slowdown.
Yeah. So let me say three things quickly, and then Amitabh can get in. The first thing is the retrospective scope is fantastic at pinpointing a date, although it's not fantastic actually at pinpointing a date. But there is no doubt that before 2009, the slowdown was happening. Now, some people, I think, I don't want to attribute this to Joe Newhouse, but, Joe Newhouse, at least in the 90s, had an idea, well, the discussion of healthcare reform changes practices alone. And, we saw that a little bit with the Clinton reform, even though it failed. We had 5 years of flat spending in the 90s, in large part because we were talking about that reform, and payers and providers changed their behavior. I will say that in 2009 and in 2008, when we were debating healthcare reform and debating cost control and trying to put in, no one thought healthcare spending had flattened out. No one did. It was slowing, but no one had. So that has only been clear to us in retrospect that it predated the ACA. It probably predated the ACA even more than just the sort of debate in the primaries, the 2008 primaries and the 2008 general election. How much of that might have been general economic factors and the Great Recession, some of that also. But the point I would make in pushing back is, look, we've had 15 years of this slowdown, minus 1 year of COVID, and we've never had, not in the last 70 years, 15 years of flat healthcare spending as a proportion of the GDP. And it ain't because the GDP has exploded with 6% growth that's kept that healthcare spend down. It's because healthcare spend has not increased that much, and that certainly it can't be attributed to the Great Recession. It can't be attributed to, I think, a lot of other factors that you might have thought, the end of a lot of patents on drugs. It really has to be something that occurred either because of the ACA directly, of the legislation, or the psychological changes that happened to accompany the ACA and the focus of the country. So I think the ACA has to get a fair amount of the credit for certainly, if not initiating the slowdown, making it persist so long. Now, as you pointed out at the start, the last point I'll make is we're at the end. And I think it's pretty clear we're at the end.
Amitabh, thoughts?
Let me start with the very last point that Zeke made. I think we are at the end. I think that there was a report from Altarum, I believe just this morning, that said, look, if you look at November 24 healthcare spending, so just 2 months ago, it grew over 7% year on year. October grew 7.6 year on year. So now we are at over 18% of national GDP coming from healthcare. We are at that. So it is sort of the end in some sense. And then when I look at the CBO projections, while they got a whole bunch of things wrong with projecting Medicare growth, they are predicting, I think Zeke would agree, that this healthcare spending is going to pick up. So that's kind of, just picking up on that very last point. So then there's this question of why. And here's how I think about it. So first of all, I think it would be crazy to say that the ACA did not have some role in this. Like now, the mechanism of the ACA we may want to kind of flesh out. So one mechanism is the ACA gets us to think about value-based payments at a scale that nobody had been thinking about prior to the ACA. That's possible, right? There's a part of me that very much agrees with that. But there were private initiatives, like the AQC, that predated the ACA. So is it all the AQC type thing? Is it the ACA? My guess is the scale of the conversation that the ACA introduced around bundle payments and ACO was unmatched by any private effort before. So I'll say that. I think the second thing the ACA does is—
I want to say what the AQC is. I'm not sure everyone knows.
Oh, I see. Just sort of think of it as like a medical home. Think of it as, what a private insurer giving a group of physicians a capitated amount of money to take care of patients. Now, you would call that an ACO, maybe not a hospital-based ACO, and it was called the Alternative Quality Contract.
And it was only in Massachusetts for Massachusetts
Yeah.
Blue Cross and Blue Shield. So that's I think, a very important point. But it was very successful.
Yeah, very successful. Now, it turns out not that successful when you bring in the quality bonuses. And that's an important point, right? Is that, does it save money? Yes and no. It saves money in the sense that, like, we use less healthcare. Did it save us healthcare spending? No, because what we saved on healthcare, we got as a quality bonus. And I think the same thing goes on with the ACOs as well. That if you look at the CBO scoring of all of CMMI's initiatives, all of them, their view is, look, a lot of these things, like, at the end of the day, added to Medicare spending. They might have reduced utilization, but we had to give them the quality bonuses as well. That's kind of the second point. The third point is coming back to Medicare and the tremendous slowdown that we've seen in Medicare per capita cost since the ACA. About a fourth of that, so about 25% of that, which is not trivial, is just the lower rates, which is very different than value-based payment. It's still the ACA, but it's just using administrative prices to reduce healthcare spending. It's not sort of, improving the way care is being delivered. So that's I think something we should keep in mind. The fourth point is the point that Zeke made earlier about high deductible health plans. High deductible health plans, which are not something that you see in Medicaid and Medicare, are over this time period growing from about 10% of the under 65 population are in high deductible health plans to the 33% that Zeke mentioned. Now, what do we know about high deductible health plans? We know that overnight, when folks are put into a high deductible health plan, spending falls 12%. Boom, like overnight. It's huge, right? And so that's happening at the same time that the ACA is being rolled out. What else might be going on? Well, David Cutler tells me that people are having fewer heart attacks and things like that for a variety of reasons. Maybe we're finally getting healthy. Maybe it's the statins. I have no idea. I sort of have not followed that literature as carefully as David had. But the point is that there are fewer AMIs and strokes running around throughout this time period. And I think the final point that I would add is that, look, at least since COVID, so this is not the entire run of the ACA, but in the past 4 or 5 years, GDP growth has been spectacular on an annualized basis. I mean, sort of the whatever ones, I mean, the past 4 or 5 years, GDP has been growing at incredible rates relative to healthcare spending. So this doesn't explain the time series since 2009, 2010, but for the last couple of years, the slowdown is a consequence of the denominator, total economic growth, growing much faster than healthcare spending. And I think that's a trend that started around the time of the 1980s. So in the 1980s, 1990s, you see this era where healthcare spending is always greater. The speed of healthcare spending is always greater than GDP growth. That starts to, the gap between GDP growth and healthcare spending growth has been falling, falling and falling since the 1970s. And now, in the last 4 or 5 years, it seems to have switched. I don't think it'll continue that way, but nevertheless, I think you've got different explanations for different periods. And when you put all of this together, I think it's just very hard to say there's one single explanation that is the most important. I mean, I think Zeke is right. I think Zeke is absolutely right. The ACA played a very big role. But saying that qualitative statement, I don't know whether that means it's 20%. I don't know if it's 30%. I don't know if it's 60%, because you've got all these other things happening at the same time.
Okay, thank you. You've raised a lot of questions about or suggestions about why we've seen the flattening of the curve. Some of it's that, we have this weird measure where the denominator is GDP, which is growing or shrinking for its own reason. I guess it's not shrinking, but at different rates. And so hard to interpret a little bit. And Amitabh, I'm going to stick with you for just a second and say, like, I know that you have raised questions in the past about whether that's even the right measure. Like, should we really be measuring healthcare spending in the US based on a comparison to the economic growth of the country using the GDP? Can you talk a little bit more about what your thoughts about that and what what alternative measures of healthcare cost growth might be?
I think that for me, like, I'll tell you why I struggle with this. Suppose we were to spend, like right now, we're spending 18% of GDP on healthcare. Suppose that number were to rise to 18.5%, 19%. Suppose it would have fallen to 17%. Well, which is the right answer? What do I want, right? And I don't really know. With just that one statistic, I don't know. I don't even know directionally if we're getting more waste or more value. And so you might say, well, you know, oh, over very long periods, it's picking up more waste than more value. And I would say, I don't really know. I don't really know. What am I really getting for what I'm spending? And that is not the ratio of healthcare spending to GDP. It's really the ratio of the health that I created to how much spending I did, and whether there were alternative ways to achieve that same level of health. So the economist in me, I realize that lots of people like this measure. It's a very simple measure. It allows for, comparisons to other countries. But in some sense, I don't really care, because I don't know. I don't know when we hit 18% of GDP whether we're better off than when the number was 17.5%. Maybe we are better off, and maybe we're substantially worse off because the increase was all waste versus the increase was all value. So I have always struggled with this number, and let me make it very concrete. With high deductible health plans, for example, I've never been a fan of them because they do save money, right? So my gosh, like if we put everybody in a high deductible health plan, I think the share of GDP that goes to healthcare would fall. It would absolutely fall. But all of the empirical research suggests, not just suggests, proves that when you move people to high deductible health plans, or when you just expose them to co-payments, they cut back on exactly what we don't want them to cut back on. And now the new research that we just put out says that they die as a result of that. They die. It's not that they might die, they die. So that's an example of spending less and killing more people, like causally killing more people. So that would be a world in which, we're saving money, we're reducing the share of GDP spent on healthcare, but we're actually worse off as a society. And so I think absent knowing what's happening to health, I think the measure, this ratio of healthcare spending to GDP is really, really fraught with a lot of problems. And health is incredibly hard to measure.
Let me respond a little bit. And maybe it's because Amitabh is a real economist that he is loath to talk about, what the right number is. I'm a, political philosopher. I'm not loath to talk about the right number. I spend a lot of time on the allocation. Look, we got a nice graph in the world looking at per capita income in a country versus healthcare spending. That graph is a very good straight line with an R squared over 0.9, and every other country's, round about that line, and we're 5 percentage points of GDP off that line. Until you give me a really good argument, like the United States is so much healthier than every other country, we have to be on that line, or we have to be pretty damn close to that line, which means we should be spending about 12% of GDP on healthcare. So we're wasting 5% of GDP in the sense exactly that you say, Amitabh, we're not getting our health benefit. And the second thing is comparing our health outcomes to every other country, developed country in the OECD. We're certainly not getting our money's worth, and we do know that we're not doing well. The only place we're really hitting it out of the park consistently year in and year out is in cancer. I'm an oncologist. I think you might have said that, Rachel. I don't want to take causal responsibility, but I mean, the fact of the matter is that's a place we have really focused. All the others, yes, MI numbers have gone down, stroke numbers have gone up. Actually, if you look at congestive heart failure, nope. If you look at hypertension, our control is getting worse. You're looking at diabetes, our control is worse. We haven't made a dent in infant mortality. We're way bad in maternal mortality, and we could keep going down the list. When you look at disability adjusted life years, we have more disability adjusted life year, and we're going in the wrong direction. So you can say up to 18%, it's clearly not adding to better health in America. If your retort then is, well, health has a lot of other components, well, then we're wasting our money spending it on healthcare services instead of all the other things that would reverse the effects. So I think in general, it's quite clear 2 points. One, 17.5% is too high objectively and normatively. We should be closer to 12%. And the increases we're seeing to 18%, we're not seeing increases in any measure of health that matters to justify those increases. So we should be spending less. I would argue the goal has to be getting down to 12%. Will we get there? Absolutely not under the current system. There is no mechanism anyone can imagine how we go from our current situation under current law down. I will say, on the other hand, if we could hold at 17.5%, and again, Amitabh and I totally agree, we're not doing that. If we could hold at 17.5%, that would be sufficient to not drain away additional resources out of the economy to healthcare that could go to education, could go to research, could go to early childhood development, could go to, climate change. So I think it's pretty clear, Amitabh, we're overspending and we're not getting health value for it objectively. We don't. There's no real indicator says that we're getting to be a healthier society at all.
But Zeke, the point is not that we are not overspending. That's not my argument at all. My argument is when you go from 17.5% of GDP to 18%, was that necessarily overspending? Now, it could be that when you go from 17.5% to 18%, maybe what you spent on were some obesity drugs, just as an example, that might have improved the health of. So in our country, the choice is not, can we go from 17.5% to 12%? The choice before us is when we cut money spending on healthcare in our country, what spending are we cutting? Are we cutting valuable spending or are we cutting wasteful spending? I just gave you an example where in our country, when we used a high deductible health plan to cut spending, we cut spending, but we kill people.
Oh,
So the choice before us is not moving to the is not getting to 12%. It's just this choice of like when we cut, do we cut waste or do we cut value in our country? That's the policy choice before us.
Amitabh, you and I are in heated agreement in the sense that how you cut really matters. And it's not just the number. I mean, the
Yeah.
number is a useful metric, I would argue, but it's far from giving you a complete picture and far from giving you a complete picture about how we need to reduce our spending. And I totally, despite the fact, probably too much information here, I'm on a high deductible plan. And despite the fact I'm on a high deductible plan, probably works for me for assorted reasons. But for most people, it's a terrible idea, and I would like to get rid of them. And I would note that no other country really has them. Only we do. And we have it for exactly the reason you say. Employers are simply getting a one-time windfall. It doesn't persist. And they've been convinced by their benefit advisors, this is how you're going to save money. And we know what happened. You're just loading the risk onto the patient, and it's a bad deal for the vast majority of Americans. But I would say we know that there's a tremendous amount of waste. We know different places where we could cut without having the effect on morbidity or mortality. And I totally agree with you. How we cut is something we need to be exceedingly sensitive to. Sorry, Rachel, I've been filibustering.
No, you've led right to the next topic I wanted to talk about, which is how do we cut? So I think that we're going to agree right for now that costs are very high and there are places that we can or should cut. But I want to talk about some of the ways in which that might happen. Maybe I'll start with, I'll stick with you for a second, Zeke. And you have mentioned the role of administrative costs in past conversations. What is the role of administrative costs and how should we think about cutting those?
Well, we're now spending $1 trillion plus or minus on administrative costs in the United States. That's 22% of total healthcare spend, maybe even a little more. We know that that's way excessive, and McKinsey and David Cutler, whose name has already been come up in very positive ways, have done, I think, excellent and detailed analyses of where those administrative costs are. One of the things I tried to do is to get us to focus in the ACA on administrative simplification and getting costs, and I blew it because I didn't craft that part of the legislation very well. No one was responsible in the federal government, and the incentive structure for HHS to do it is almost zero because of that $1 trillion, about only 80 billion is federal government spend. The rest of it really accrues to payers, providers, and physicians, payers, hospitals, and physicians, and they can't get their act together to do it all right. But there's a lot of money there. 21% of the 250 billion dollars is financial transactions, claims, billings, and payments. That can be simplified, and the savings there is, between 50 and $100 billion. And that's the kind of thing that no one will shed a tear if we actually organize it. And the reason we have it so expensive is because you have these multiplicity of payers with their multiplicity of coverage policies, with their multiplicity of copays and deductibles, and how you have to file your claims and stuff that, just drive up costs that you don't see in other countries that have standardized that. And I think that's just one example. The other example is, remember, from a hospital standpoint, a large part of the savings are internal operational processes, HR, and other things. And my view is that to the extent that they can raise their prices, they use their leverage to get better prices out of payers and insurers mainly. The incentive structure of going through all the work of rejiggering internal administrative processes to save money is gets less attention, less urgency, less human resource talent. And so we leave a lot of money on the table. If prices were capped the way they are in most other countries, or you got a global budget, the attention you would spend to being more efficient would increase because you wouldn't have I can raise my prices alternative. And I think that's one of the things we're losing out on. So I think administrative costs is a big bucket, but it's far from the only bucket. We have inefficient costs, we have unnecessary care, and I think there's a lot of that element that we could get, and then we have just overpayment for routine services that we know that our physician fee structure is imbalanced in a very, very negative way.
Okay, thank you. Amitabh, how about you? What are your favorite ways to reduce costs in healthcare?
Well, one is I'm going to agree with Zeke on this. I think the administrative cost problem is even worse than
Wow.
we acknowledge because of let's just go back to this ratio we keep talking about. 18% of GDP, comes from healthcare or is spent on healthcare. That actually doesn't include the full total of administrative costs. Like all the HR departments at the thousands of employers are not showing up as healthcare spending. That's showing up as labor spending. All the benefits consultants that are basically replicating the same lousy package for all of the employers, they're not showing up as healthcare spending. That's just showing up as like another industry. The problem of administrative costs in a sector, the private sector, is enormous in terms of what it's doing to the fiscal bottom line of companies, what it's doing to the take-home wages of employees. I think so. So my own view is we have some first-order problems on the private side of our system. First-order problems, actually, that and Zeke said this at the start of this call, that employers have really not let on. In fact, they've bought into a whole bunch of things like wellness that just absolutely do not work to save money in the way that they've been thinking. So that brings me to, well, what can we do? My own sense is we're not going to be able to take on the private market. If people want this lousy private market, let them have it. The largest insurer in the United States is now the federal government, right? And it's the 50 states. Let's make public health insurance in America work as well, as efficiently as we can. So what can we do there? I'm going to say something controversial. At a high level, I don't think that we're really going to get a handle on costs or value unless we have the following conversation. How much healthcare is a right? Right? So people always say healthcare is a right, but like, what is the minimum floor that we need to give every American? If we could figure that out and we could deliver that as a plan to every American, my guess is that plan would be quite cheap. Most people would be enrolled in that plan at birth by default. Maybe you could buy that plan on an exchange. Right now, the exchanges are only 5% of sort of all Americans, but you could offer that plan. You could enroll people in this basic plan with basic coverage. And then, if you want to choose to be in the private plan, go right ahead, be in the private plan, right? But I think kind of moving the public insurance plans to this sort of basic plan is going to take some effort, but I think that there could be a real opportunity, a real bipartisan opportunity to start that conversation, because I think it's a way to reduce healthcare spending and it's a way to actually improve health. Because I think Zeke has made this point over hundreds of essays, the kinds of things that really improve our health are not necessarily investments in healthcare. So my guess is the basic plan that people want for like cancer care, even expensive cancer care, even expensive high-cost drugs for cancer care could be in this basic plan. And cancer still, thankfully, is rare. My guess is the basic plan would not be expensive. Now, how to structure this? I think Medicaid provides a great chassis to structure this. And I think over time, you could start to think about moving MA plans onto this exchange. It's iconoclastic, but I think all the basic architecture is there. And I think in the basic plan, personally, there should not be any cost sharing. Cost sharing, I think, is a very narrow 1980s way of thinking about how to reduce waste in healthcare. I think we don't. I think you have to really be an oncologist or an economist to be in a high deductible health plan or even manage low copays, and that's not most people. So that's kind of my big answer to your very precise question,
I'm
Rachel.
going to call that your big infeasible answer.
Well, wait a
I
second. I don't think it's infeasible
I
at
don't think
all.
so.
I would say I agree with Amitabh mostly in the following sense. I do think we need to simplify the system. I think one of the things that has plagued our system is complexity right from the start. And we need to simplify and standardize not just our medical delivery, but the operations of the system. I have proposed in writing a book about, we need just two ways of getting insurance, employer sponsored and one exchange where everyone else is in and employers can dump their people into one exchange with one set of standardized benefits, standardized co-pays, and a very limited number of competing insurance companies in any single market because people like some choice. Where I disagree, and this is, I think, really important, is the idea of we'll have a essential benefits package, a skinny benefits package, however you want to describe it, cost effective. This has been a pipe dream of economists for a very long time. We can get just the essentials in here. I'll show you, Amitabh, lots of my scars. Right? We put in, you're going to have essential benefits, have 10 benefits, and then we kicked it to the National Academy to say, what are the 10 benefits? And then we did a survey of all the fact is there's no agreement there. There's never going to be an agreement as far as I could tell. And I don't think that's a path to go down. I think we need to put the responsibility in the right place. And by the way, I totally agree with you. And I've written this also that, copays are ridiculous. They prevent the goal is to prevent moral hazard and overutilization. You don't need we know you don't need high copays for that. That's the first thing. And the second thing is when you got a disease like cancer, what's the point? There's no moral hazard here. There are some places you could choose something cheaper, not get proton beam and get IMRT radiation. But that responsibility ought to be in the right place, which is the doctor, not the patient. And we ought to make doctors fiscally responsible for efficiently delivering the care. And that is zero copays and and structure the reimbursement system so doctors and hospitals have that responsibility. But I don't think the approach, and this is where I disagree with what you've outlined, is get a skinny package, an essential benefits package, whatever label you want to put on it. We're never going to get there. And maybe that's what you were referring to, Rachel. I just don't think it's feasible. And plus 5% of the population is going to be really damn sick with really expensive conditions. And you have to figure out how you're going to cover them. So
by the way, it doesn't mean that you're not covering expensive conditions. In fact, that's probably where the value of insurance is greatest. So you would be covering probably all the really expensive drugs for cystic fibrosis. You would be covering all the frontline cancer therapies. You would. But you can do the actuarial math and covering those high cost therapies, not necessarily drugs, but even like a level 3 NICU, level 4 NICU. If you run the math on what is the budget impact of those things, it's small, even though the health impact is quite large. I think this would be an opportunity to say, for example, it's sort of doing what the marketplace plans are already doing, right? It just so happens that it's 5% of plans that are able to say, we're not going to cover the really expensive hospitals in Boston. But, if you need a level 4 NICU in Boston, it is covered at one of those hospitals. I think that's what's missing in the way we're designing healthcare. And we're acting as though simply because the plan is a private plan, it has figured all of these things out. So I was looking at the formularies for some of the largest and most prestigious insurers in the United States on whether they cover all the orphan drugs. And I thought there'd be wide, consensus that they all cover the orphan drugs. No, they don't. Do they cover all the breakthrough drugs? No, some do, some don't. And it's not really always grounded in medical experience. So my guess is, relative to where we are, I think standardizing. Look, there's no innovation in insurance. I'm actually quite happy with the insurance market being totally regulated. The insurance is all in new devices, new drugs, new delivery system. That's where I worry about regulated prices coming in. But if you want to regulate the insurance market, this is the basic package. This is what you have to cover. You have to put up the evidence that you're using to decide what you cover and don't. I think it's not really going to squeeze in innovation a whole lot at all.
So
Well, we're in heated agreement.
Amitabh just said regulated prices. So that's one, we haven't talked in depth about that, but that's one potential solution. Another thing we haven't talked about is consolidated markets and antitrust enforcement. And so we only have 9 minutes left, but maybe we could spend a few minutes talking about those as potential solutions. And actually, there's a third one we haven't talked about, which is price transparency, which is always on the list of.
Well, we can dismiss that. Price transparency.
We can dismiss that
great.
one.
I think this is another pipe dream of employers.
Yes.
I think this is just there's no evidence that consumers, patients want to use it. I am shocked that capital markets and employers seem to think it's the way forward. I think this is like a Silicon Valley pipe dream.
Yeah.
Okay, so
Well, Cashlight made a lot of money off that pipe dream, but no one else has.
So regulated prices. How about that one then?
Yeah, I think you're going to have to regulate prices. And as Amitabh said, look, we've had relatively stable costs per person in Medicaid and Medicare, and they regulate prices. And look at every other country; they regulate prices. And in Germany, right, they have a very interesting system in that this government gives money to the physician groups like the AMA, and the AMA then pays the doctors. And when they run out of money, right, they pay 80 cents on the euro to the doctors. And the doctor said, but we gave this service. Well, you guys, it's like an SGR, but the person administering the SGR is the AMA. And Taiwan has something very, very similar, that they know quarter to quarter how much they're paying, and they adjust. We're not paying a dollar for dollar. We're going to pay you a fraction. I think living within a budget is going to be really important going forward. We've resisted it in America. I think it's coming. And the important thing would be it coming with teeth. And the important thing would be that it's all in, not just the government programs, but all the programs together. I think that's going to be, that has to be one of our tools.
I think as the share of government in healthcare grows, regulated prices are just inevitable, because that's government's sort of that's the primary tool it has. I think that, and I've written with Sherry Glede on what we can do with regulated prices and the opportunity with them. But at the same time, I do think that in a world where you don't have any private market, and we're not in that world at all, but I guess there's a version of regulated prices I don't like. And that is a version where there's no private market. So what I worry about is a world in which the government uses its monopsony purchasing power to regulate the prices to solve its budget problem. But in doing so, cuts out a provider who's actually expensive and super valuable. And there's no private market that can figure this out. So I'm all for regulated prices as long as there's a private market that permits this top-up option. That's why I like top-up options, so that in the chance the government gets it wrong, in the chance that the government takes its idea of regulated prices, let's just take all the current Medicaid prices and cut them 20%. My guess is that would have some bad impact on some providers, right? Now, Zeke might say maybe not, because we're still spending more than the UK. I would say no. My guess is some providers would really, really start to cut down on high quality care. Now you need a private market that can say we'll pay more for those providers, and you need a switching mechanism. It's almost as a discipline device on the market, on the regulator.
I concur with that, Amitabh, and you come at it from the market standpoint. I come at it from, look, some people want to spend more of their money on healthcare. Totally. I'm all for that. You've got you should be able to establish your priorities. I might think that's idiotic, but you might value that. I have a brother who, an MRI every other day would probably make him very happy, but it wouldn't make me happy.
Okay, I have one last question, which I would love for you two to weigh in. The world in which both of you just described, where you're allowed to top up, really in many ways is at risk for creating an inequitable system, like a two-tier system, right? Because people who can't afford to top up aren't going to be able to afford the high-value providers that Amitabh is, saying are being squeezed out. So I'd love to just talk a little bit more about the final question for both of you. Your vision of a future program that accounts for rising prices and providing equitable care. This is a different question than what I told you I was going to ask, but you're both smart and can handle it.
So let me say about that. I've written from an ethical standpoint how we should think about that. If topping up does not compromise the ability of everyone else in the system to get what they want and what we think they deserve, topping up is perfectly ethical. If topping up compromises, right? So if someone can buy a GLP-1, but that means that the people who really need it for their obesity or their diabetes can't get access to it, then it's unethical. Okay. I initially was pro concierge medicine. I think someone wants to pay $2,000, whatever the money is, to get a concierge doc who's only got a panel of 500-600 people, can call them at any hour, blah, blah, blah. That's fine. When concierge medicine becomes so prevalent that it undercuts the number of primary care doctors, so no one can get a primary care system unless they have a primary care physician in a timely manner, unless they have concierge medicine, then it's unethical and it needs to be constrained. That's the way I would think about it. So there have to be limits on topping up. Don't get me wrong, but that's the limit you want when it really affects the underlying guarantee of healthcare services that everyone in the country it should be guaranteed as a matter of course.
I think for me, I agree with Zeke. I mean, if the topping up creates some rivalness, then it's a problem. But if it doesn't, I don't really have a problem with it. And I don't have a problem with it for two reasons. One is just that the demand for the willingness to pay for small improvements in health is going to vary across the population. Some people are using a QALY of 100,000, some use 50, some use 400,000, not because they're stupid, because some people really value living from 90 to 91. Some people would say, I don't want to live that from 90 to 91 or 99 to 100. I want to give that money away. That's great. But we should allow for that heterogeneity in the population. We don't all live in the same house. We don't all drive the same car. Why do we think that the willingness to pay for improved health would be the same across the population? So that's one reason I like the top up. The second reason is it's this discipline on the growth of government. If the regulated prices become too low, how would we know? The doctors would all start to quit. The hospitals would start to close. That is not a good place to be. So I think you need this private market. I mean, if people start to switch to the private market, it's a signal that the government plan is a lousy plan. So it's a way of sort of learning about the quality of the government plan. And it is absolutely not my view that the top-up plan is the great plan. Actually, the top-up plan has in it a whole bunch of marginal therapies that only some people, Zeke's brother perhaps, value. The great therapies that actually improve our health are all in the basic plan. So in some sense, if everyone's happy in the basic plan and there's very little take-up of the top-up, that's a sign that you've got a great basic plan. If everyone's in the top-up plan, it's a sign you got a lousy basic plan.
I would say a lot of countries that have a government, whether it's single payer or some other arrangement, have top-up plans, and they're depending on how you structure things. Like in France, almost everyone's got some top-up plan because that's the way the government plan is really thin. Netherlands has also a lot of people have top-ups. So I think it's it's important to have that as a safety valve. And even when many people are using it, again, as long as the government provided plan is robust and good, I think the ethics support having a top-up plan.
All right. I would love to keep talking about this, including your thoughts on political feasibility of this, but I think it's 1 o'clock. So I want to thank you both for joining us today. It's been a really great conversation, and I appreciate you taking the time. I'm sorry Melinda couldn't be here to join us as well. I want to thank the audience for sticking with us, and also to ask you to join us for our next event, which is a related topic, the big business in healthcare. And actually, David Cutler, whose name came up several times, is going to be joining us for that conversation. So we hope to see you then. And until then, thanks for joining us.
Thank you, Rachel. Thank you, Amitabh.
Thank you, Zeke. Thank you, Rachel.
Good to see you both.